So this has been absolutely wonderful so far, and I feel like I won the prize with this panel. So we have yeah, exactly right. I think we all feel that way. We have incredible rock stars in the room and here. I think most importantly, the three of you have been so deeply involved in this work and in developing the term age-friendly care and age-friendly healthcare. So let's start with introduce yourselves, but let's really define age-friendly care. Let's get down to the details of what that means, and then we'll see how it comes together.
Happy to do that. Thanks, Jill. Thanks, Mike Dowling, for this incredible opportunity. And I was thinking this might be one of the most important talks I ever give because of the people in the audience, and I'm just so glad to be with all of you. I'm Terry Fulmer. I'm the president of the John A. Hartford Foundation here in New York City. Our money's from A&P grocery stores, which everybody always goes, huh? And I'm a nurse. And when I began thinking about age-friendly health systems, it was because people were talking about age-friendly cities, age-friendly communities, and I said, well, how can you be an age-friendly city if you don't have age-friendly healthcare? And so we began that work. Age-friendly is not a cheap moniker. The WHO started that language in 2006, and we paralleled it intentionally because we have to have continuity of care across all settings, whether you're in a hospital, a prison, a nursing home. And so the words matter, the measures matter. Age-friendly is a robust set of strategies based on 4 M's, what matters, mentation, medication, mobility, and they are delivered as a set. Each of those are evidence-based practice protocols developed by our geriatric scientists over many decades and funded by NIA and foundations like ours. And each of them have outcome measures that you're able to not only understand what your score is, but your change score. And you all must be working on that change score every single day. The last thing I'll say, because somebody asked me to say it, is that only 2% of private philanthropy goes to aging. And so that's something we really want to address. So
the words matter, the evidence-based
absolutely
work matters, and we need to implement that work.
That's right. Otherwise, we're just admiring the problem.
Right, or just calling it a name.
Yeah.
And then we have to actually do the work.
That's right.
And measure it. And we had that discussion actually last night about how do we actually measure the evidence-based care that we're delivering. Jenny, how about you? Introduce yourself and what it means to you.
Sure. Jenny Chin Hansen. I live in San Francisco. And what's listed in my bio right now is I'm the former chief executive of the American Geriatric Society, which is the society of physicians, nurse practitioners, and other clinicians that focus really on complex older care. And also the fact that I'm an advisor to the Milken Institute that has a center on the future of aging, but specifically for Alzheimer's. But what's not listed, but probably my tagline the most, is I spent about 25 years in San Francisco with a community organization called Unlock Senior Health Services. And over the course of the 25 years, had a chance to work as a researcher, operations director, executive director, CEO, and carry the ball over the line to have this become a Medicare benefit. New York here was one of our first sites with what was called Beth Abraham at the time and now is Center Light, and has the biggest PACE program in the country. And we're in 31 states. So bottom line is the other thing I do now is I work in San Francisco with helping establish accredited geriatric emergency departments, and that has been great. So age-friendly, I think one of the things that is fabulous that has been done, and you'll hear from Kedar about IHI's role, is that we've taken the scientific information, measured it, looked at accountability. Something I want to say on behalf of the John A. Hartford Foundation is that next year, CMS, the Center for Medicare and Medicaid Services, is requiring every hospital who gets public money to attest that they are doing something related to age-friendly, what Terry has brought up. This is incredible. And a major achievement.
Pretty proud of that.
That this is a reportable event. And so age-friendly now is not just for special projects and locations.
Absolutely right.
This is for every hospital in the United States. And so that, I think, is having hospitals who ironically care for almost half their patients are older persons. There's not been a geriatric focus. And why? I don't know if you realize that right now in the United States, there are only 7,300 geriatricians in the country. Do you know how many primary care pediatricians we have? 57,000. Yeah. So we have such a turnaround that we don't have enough clinicians ready, but we can develop the systems and have system call for accountability. So therefore, we have culture, practice, and accountability.
Yeah, and also, we don't want to just do pilot programs. We want to implement at scale across our organizations. And when you started with the community-based organization that you started with, and the collaborations across those organizations are vitally important as well.
Thank you.
Kedar, we had a conversation about age-friendly care and maybe what that means to you. And I was lucky enough to read that in the new book, The Aging Revolution. So you might want to introduce and maybe share.
Thanks, Jill. First of all, let me just say everything I've learned about the care of older adults, I've learned from these two individuals on the stage and so many of you in the audience. So it's a real thrill, a real pleasure for me to be here to talk about our work on aging and age-friendly health systems. I had the privilege of being in the room when Terry came to IHI and said, I have this idea about creating age-friendly health systems, age-friendly healthcare. And I just remember thinking, this is going to be something incredible. And then when the first health system that we know of started with age-friendly and put what matters to you matters to me on the back of a T-shirt, I knew we had started, in fact, a movement on age-friendly healthcare around the country. But age-friendly to me, as you're saying, Jill, I had the privilege of writing the foreword of the book, and I put a story in that foreword about my grandmother. And for me, age-friendly has always meant the care of older adults that are important in my life. And my grandmother has been a central figure in my life for all of my life and remains so even though she's passed. But her story was one of ageism and really neglectful treatment of her as she aged later on. Her primary kind of goal as she got older was to contribute to the family, to cook the meals and to hang the clothing, the laundry, and to do the things that were important to her. That's what she found purpose and identity in. And as she got older, she developed very severe osteoporosis in her spine, and she was being very undertreated for pain with essentially a broken spine. And when I got that phone call that some of you have received, that your mother or your grandmother is dying, get to India if you want to see her before she passes, I hopped the next plane that I could find, got to India quickly, and walked into essentially the scene of a deathbed. She was on the bed, the candles were lit, the songs were being sung, the incense was lit. And I started, after I touched her feet and said hello and greeted her, I very quickly started asking questions. Sorry, the training came out. I started asking questions about her care, and very quickly realized that she was being completely undertreated for pain, for depression. She was severely depressed because she couldn't do the things that mattered to her in her life. And ultimately, with a very simple and gracefully somewhat lax prescribing rules in India, I was able to, and we won't, that's off the record.
Right. That in Atlantic City.
Yeah. But I was able to, essentially care for her for 2 weeks, became her kind of primary care doctor, essentially, or I now like to say her geriatrician. We ended up treating her pain. We got her physical therapy. We treated her depression, and within 2 weeks' time, she was climbing the steps to watch her, to watch the sunset from her favorite place in Bombay. And she lived 10 years after that point in time.
Right.
And I got to see all of the births of her grandchildren, her great-grandchildren, I should say. And, it's just a story of how the system really neglects to treat older adults. So when I went to see her doctor, I left this part out. When I went to see her doctor to say, she doesn't need much, just a little pain control and some antidepressants, he basically said, she's old. You know that, right?
Right.
And I was like, look, this is not a complicated case to treat. Actually, it turns out, and very quickly I realized that older adults are actively discriminated against in health systems all over the world, simply on the basis of their age.
It also resonated with me in the book when you said, when we treat older adults in the correct way, how many more family gatherings, how many more weddings, how many more sunsets can they see?
Yeah.
And it really brings to life what matters most when you ask somebody what they want.
Yep.
And we talk about, to go on to another thought, we talk about integrated and patient-centric care.
Yeah.
And we don't accomplish it most of the time. And now you take an older adult that has multiple complex conditions as we age. How do we, and I'm going to venture to say that geriatrics as a specialty defined team approach. So Jenny, let's start with you. How do we, as health systems, how do we collaborate across teams to really deliver at a health system and beyond the walls of the health system, which we've heard so much about today, that coordinated patient-centric care?
Yeah, when we look at how we're trained and the institutions, we're trained in disciplines and specialties.
And disease-specific, which was said here today.
And so what happens as we get the opportunity to live longer, it's so often that we have several conditions. And so one of the things that we don't do well is when somebody sees a cardiologist, a neurologist, and a rheumatologist, it's left oftentimes to the person themselves to have to raise a story. And then those physicians or nurse practitioners say, well, what medicines are you on? And this is just such a huge burden. So this is such a representation of normalcy, but it's totally uncoordinated. And it is a burden to the family or friend caregiver who's trying to tell the story each time. So the system is just designed to be trained in that way. You become experts, but you don't realize that the medications, as well as the conditions of treatment and the emotional and psychological factors, actually intersect with each other. So some of the models that you've been hearing about are attempts at bringing this together so there's a holism. And we talk about precision medicine. What we should probably think about is precision focus of care, so that what matters most to the person, coupled with their empirical clinical issues, have to be dealt with as an ecosystem.
Yeah, I would agree. And Terry, that's also not just collaboration across disciplines, but it's also the outside organizations, the community-based organizations, the social services. Your thoughts on that?
That's absolutely right. And so we talk about the age-friendly ecosystem. We've written about that. And it's all about sharing a common language and making sure that everybody's empowered to use that language. When a nursing assistant calls me and I'm at the bedside in the hospital, we should be talking about the 4 M's. We should all have the same words and the same thoughts and meaning. I am thinking about the conversation today, and I do want to say that we love saving people, but we don't like taking care of them. And we know that. You know, we love that, and we love to tell people we're 100 years old. Oh, we love that, but we don't like taking care of people. So we've got to change that. And we have to shift from ICD-9 codes to function. I may have diabetes, you may have diabetes. I might be water skiing, you might be in a wheelchair. So what are we talking about? We're talking about function. And when we shifted and had our age-friendly health system, all of a sudden, Kater and I noticed that we were in like 15 countries. And in open school, IHI, and thank you to IHI, thank you. When we were in open school, and there's like 40 countries involved, and why is that? It's because age-friendly transcends language, religion, payment. You can move or you can't. You can take your meds or you cannot. And what matters to you is so vitally important. That's not what you asked me, Jill.
Right.
And I knew that.
I want you to get whatever you want to get out.
But I'll go right ahead and now.
But I know that was good because it's the function. Just like it's health span. We talk about lifespan, we talk about health span, and we have to really understand how to implement this. And certainly you have work to do that. And yeah, and the IHI. I mean, you've worked across those organizations. And how have you helped health systems implement this and work across the silos that actually we're taught. That's how we're taught to deliver care. We have to change that education as well.
Yeah,
and
you
you've
know,
certainly
one of the things
played a
I think
major
about,
role in that.
yeah, one of the things I became very clear to us very quickly in the age-friendly work that we got involved with the Johnny Hartford Foundation and Terry and her team was that there was considerable observable variability in care. And
Yeah.
these are the two vital ingredients, in my view, to improving any system. You have to know that you have to have observable variability. There has to be variation in care. Some people treating older adults successfully and well, and we had lots of that. We had islands of excellence. Many of you in this room had created pilot programs or research studies that had provided far superior care to older adults.
Right.
We had real pockets of excellence across this country and across the world. And you had to have the ability to understand that there were places where that did not exist, which was the vast majority of the places in the country. Our internal study at IHI showed that only about 10% of older Americans were getting care consistent with what we would regard as high value practices in geriatric medicine. So that meant 90% of us were not, older adults were not getting or receiving that kind of care. You had to have observable variation in care, and that created the incentive and the ability to make improvements. We then took the literature, distilled it to these 4 key concepts that both Jenny and Terry have described, because we knew that we couldn't spread hundreds of things to every system on the planet that would not have a certain kind of stickiness. And the 4Ms, actually, I don't know how, Mary Tinetti was on the stage earlier,
Yeah,
and I think it was Mary actually that first articulated the 4Ms, or maybe it was 5Ms at the time. But when we saw, again, T-shirts being printed, there was another system that had M&Ms of different colored varieties that they had designated for each of the 4Ms. And when that kind of stuff happens, like our thinking is there's campaignability around this. There's a spread scale kind of dimension to this. And the other factor I will just say is that every single person that we met in the work, whether they were in Saudi Arabia or in New York City or wherever, almost every single health system executive, minister of health, or leader could think of someone like my grandmother. They could
Yes.
think of someone in their lives
No, right.
who had not been handled correctly or well by the health system. And that ability to connect your own story to the larger narrative is a key principle of scaling and spreading almost anything. And I think we found that in Age Friendly, and that's precisely the reason it's now in 5,000 health systems around the planet.
And that's the point. In other words, you walked into your grandmother's home and took care of her. Not everybody, we shouldn't rely on that expertise of a family to have that access, as opposed to knowing what the evidence-based guidelines is, or knowing what works. And we've implemented 4Ms across Northwell. We need to do it better, but it's with the partnerships that we've been able to do that.
Sure.
That's right.
Jenny.
If I can build on it, we're talking about 5,000 systems around the globe. One of the things that I think we have a tendency to do is we create some wonderful approaches, gathering evidence and data. But what happens is the consumer isn't always included in this. And so, the ability to have only so many geriatricians and people who are really specialized, I think we have to democratize and deputize the public to understand what the 4Ms are.
Yeah.
Because if they are aware of mentation and medications and mobility and what matters, if they're ready, if they're doing this on a secular basis, you can plug and play once you get into the hospital system or any institution, so that there's agency on the part of the public, because there are not enough clinicians to be all the experts and all the training. But because it's your family knows that, my gosh, after coming home from a hospital, there's a Medicare benefit called MTM, medication therapy management. You do some studies to coordinate those medications to make sure you're on the right medicine, because so often when you get discharged, you get a prescription and it's on top of what you're already taking without even knowing it. So you are overdosing. So there are things that the public should know and be deputized to take care of themselves. And then so when you interface with the medical institution, this is not just such a foreign language. There is alignment.
Well, we're not accustomed to bringing the patient and the family into the conversation all the time. I mean, we're taught to round outside the room,
Yeah.
you know, as opposed to talking with the patient about what's going on. The other thing is we need innovation, we need new technologies, and we need all that to change the trajectory of disease. But we have to do the things that are also right there in front of us, like medications. And when someone goes home on their 4th diuretic because no one checked that they're on the 3 others, it's different. I mean, that's actually not complicated, but we can't learn how to implement that at scale.
Right.
And I think that's what we have to work on.
I'm going to do a quick build on
Yeah, go
Jenny
for
to
it.
talk about the public. And here are some strategies that we are currently trying, and we welcome every one of you to give us better ideas. We work with NBC, and we have them do forum spots. And I've gotten calls from people in Indiana saying, Terry, I just saw you on the Today Show, and I promise you, they didn't. It's a shameless infomercial for age-friendly, and we're serious about it, and we're trying that. We also created the first web page on WebMD on age-friendly and geriatrics. They didn't really have a geriatric page before then, because we know that a lot of people go to WebMD for their answers. Finally, we have 100% of CVS Minute clinics in this country are now age-friendly. They have a database of about 8 million visits.
Yep.
They can tell you their structure of their electronic health record is such that you can't bypass any of the M's. You won't be able to start and complete a visit. And so there's a lot of CVS's. I guess I have to get to the dollar store next. Maybe I'll try that. But I think that, you know, every vector we can possibly use, and giving out cards to people saying, here are your forums, ask your clinician for that. And that's part of the report card. So building on that public.
Now, what also, it's the care model, right? Because we can't rely on the number of geriatricians that exist at this point in time. So the care model also has to shift, and that's
right.
certainly one of the major shifts. If I could just talk about healthcare policy for a moment. In terms of age-friendly care, what's working, what needs to change, how do we become more flexible and more nimble? Maybe Kedar.
Yeah, sure. So Jenny's already mentioned the CMS structural measure that we had put in place. There was a combined effort by the Geriatric Emergency Department colleagues and the Geriatric Surgical Verification Program and our age-friendly work. But these 3 organizations came together to develop an age-friendly structural measure, which now CMS has endorsed and placed into the rule book. That helps. You know, that helps a lot to actually get hospitals to start thinking about becoming age-friendly and actually participating in the activity. It's ironic to me that CMS has a birthing-friendly designation, but not an age-friendly designation. It seems kind of backwards in some ways, and it doesn't make any sense. They're the Medicare and Medicaid. I mean, there's a clear population that's being served that does not have a age-friendly designation. So we've been working hard on actually, and collaboratively with our CMS colleagues, to actually design and create an age-friendly designation for all hospitals that meet the structural measure and go slightly beyond that. And I think there's probably incentives that could be put into place in value-based contracting for understanding what matters to older adults. First of all, asking the question. There are incentives and already built around goals of care, but asking and responding to what matters to people, and then building actually learning systems that allow exchange of information across health systems that are working on providing better care for older adults. Those are 3 areas that I think would help from a policy perspective. Can I make one other comment, though, on getting straight to Jenny's comment on we have to work not just on the supply side, which all of these target, but also the demand side.
Yeah.
There is a My Health checklist that we created together with the Hartford Foundation some years ago to try to help coach family caregivers and patients to demand the 4 M's from their care providers in some way. And I think that is the start of that notion, but there's something very intuitive, I think, about inviting family members into this conversation about understanding what matters to you. It's not a difficult technical conversation that I think sometimes we stumble around. But getting into the discussion of what matters to you is a good entry point into sort of inviting the family into that conversation of having really a conversation about the 4 M's with their providers.
It's about empowering the patients and their families to be able to do so, and we have to continue really to do that. One more on policy, Jenny. We have about a minute left, and maybe I'll have a couple more comments left, actually. Anything more on healthcare policy?
Yes, thanks for offering that. One of the things that has been brought up along the way in this conference already is the shortage of housing and the issues here.
Yes.
One of the things that we have in San Francisco at UCSF is a center supported by the Benioff family on homelessness. And something that people probably do not realize, it was only frankly a few years ago that I realized it, that half of the people today who are homeless are over 50 years old.
Yeah.
And of those people who are homeless, 41% had never been homeless before. So the economic strata on Maslow's hierarchy of food, shelter, and basics is right there, that more and more people are losing their housing. So we talked about Harlem not having enough housing, but people who are in housing are just like one medical episode away to being that poor. And so I think that's something that, going back to the phrase social determinants of health, the basics of being able to live in your own apartment in a way that is affordable is so key, because people either lost their jobs, say especially during the pandemic and in 2008. The economic base is shrinking while the population base is growing. So here we celebrate longevity, but longevity without basic housing and resources is not ideal.
No, it's longevity for all, it's age-friendly care for all, but it's also where Michael began, which we have to define health very broadly. And it's whether it's housing, food, transportation, and actual medical care altogether is what we have to accomplish.
And I wanted to just acknowledge Dr. Margot Kuschel, who is an internal medicine physician based in San Francisco at UCSF, started this whole body of work about 20 years ago. So she's been tracking this, and this has gone national. Every community, whether it's rural or whether it's a big urban area, is going through that experience right now.
Wonderful. So I just want to thank this fabulous panel. It's a pleasure to be on the stage with you. So thank you so much.
Thank you.